Well, ladies and gentlemen, friends, colleagues, guests, partners, I think this partners is the correct terminology. A very, very warm welcome to the second Partnership Strategies Forum of the Melbourne Brain Centre at the Royal Melbourne Hospital with our key strategic partners, which is, of course, the Florey Neuroscience and Mental Health Institute, and we're delighted that Professor Jeffrey Donnan, the director of the Florey, will say a few words after me. The University of Melbourne, represented by a number of us, but particularly want to thank Professor Trevor Kilpatrick, who's the director of the Melbourne Neuroscience Institute, and the other major group sharing this wonderful Kenneth Myer building here in Royal Parade. The last decade, and in particular the last few years, has seen an absolute revolution in the organisation of brain diseases in Melbourne and in Victoria, and this wonderful precinct here in Parkville and this magnificent building that we're in, the Kenneth Myer building, incorporating the Melbourne Brain Centre, which is linked so closely with the Melbourne Brain Centre at the Royal Melbourne Hospital and the Melbourne Brain Centre at the Austin Hospital. And this is truly a fantastic collaborative partnership, and what we're trying to do is to do brain research across a number of key areas which you're going to hear about this morning to advance knowledge and ultimately treatments and better outcomes for patients. That's what we're all about. We're doing research to try and get better outcomes for people with brain diseases. Now, this was the sort of format that we used last year, and there will be time for discussions and interaction and engagement, because this is all about building on our initial forum and building partnerships with our key strategic partners, none of whom are more important than the consumers. And a particular welcome to consumers today, that your ideas, your thoughts about priorities for research, your comments on our program and how we can perhaps better achieve our collective aims will be enormously valued. So I've got to twist around here. This is what it's all about this morning. It's discussion and engagement between the people that are doing the research, perhaps the people that are directly benefiting from the research, and other key stakeholders in the process. So we're working together to improve patient outcomes. We want to discuss across the broad range of research areas here, current research projects and future research plans. We want to focus on what should be the priority areas in terms of areas of need, and identify new partnership possibilities. Now, let me emphasise, we do work in a unique collaborative consortium in Melbourne, and you're sitting really at the centre of this collaboration, which is one of the leading neuroscience collaborations in the world, and you can see here the key partners which I mentioned before. So the overall mission is to translate basic research across the spectrum of clinical research, all sorts of aspects of clinical research, imaging, pathology, databasing, clinical trials, but ultimately the whole idea is better outcomes for our patients. These are some of the key brain research areas that we're involved with in the Melbourne Brain Centre, and with our collaborating partners: stroke, brain tumours, psychiatry, neuropsychiatry, epilepsy, movement disorders, multiple sclerosis. And you'll hear about some of our key platforms: clinical trials, imaging, databasing, and epidemiological work. These are the common brain diseases. Most people, tragically, at some point of their lives will be touched either personally or by a close relative or friend that suffers from one of these conditions. I'd like to warmly welcome the partners and the support groups. I won't read them all out, but the key partners are all listed there. But I know that there are individuals. We want this meeting not just to be about organisations. This meeting is about people and partnerships, and we're grateful to each and every one of you coming along today. So I'd like to, before handing over to Jeff, just again to thank you all. I'd like to thank Fiona Rogers, manager at the Melbourne Brain Centre at the Royal Melbourne, for her great work in putting together this partnership forum. I'm now going to hand over to Professor Jeffrey Donnan, my very close friend and colleague, Director of the Florey. Thanks, Jeff.
Stephen, thank you very much. It's wonderful to see so many people here to be engaged in this whole research program, which says everything about research today. I think it's got to be relevant, it's got to be of exceptional quality, and it's got to have outcomes that are going to benefit all of us. If I could first just say and acknowledge the extraordinary leadership of my friend and colleague Steve Davis, President of the World Stroke Organisation, in bringing all of this together at his centre over at the Royal Melbourne Hospital. And I think Stephen and I would say one of our small contributions has been to be able to bridge this Royal Parade gap, to have collaboration between the University, the Florey and the Royal Melbourne Hospital and the broader research community, many of whom are here today. If I could just say a couple of words about research, and this applies to everything about neuroscience research today, from research on epilepsy, multiple sclerosis, stroke, brain tumours, etc., that it's the new black. When Steve and I started as young neurologists, you could say that research in neuroscience was static. Progress that was being made was incredibly modest, and perhaps that's one of the things that attracted both of us into this field, in that we could see that there was such an immense amount to do. And I think we would both say that we've been absolutely staggered, the amount of progress that has occurred over this very brief period of time. It says also what we're able to achieve over the next decade or two to make outcomes much better for you and I. If you take our area, stroke for example, when we started, there was zero evidence that we had any way to prevent stroke. There was zero evidence that we could improve stroke outcomes after it had occurred. And zero evidence that we could prevent further stroke after the first stroke. And now, as we all know, there are half a dozen strategies to do exactly that in each of those categories. Absolutely staggering. And I make that point to say that these developments have driven management. So if we consider the introduction of aspirin for stroke, the introduction of TPA, the introduction of the evidence that stroke units work, has driven an evidence-based change in practice worldwide. And without that research, this just would not have happened. So this is the driver of better outcomes for all of us. And there are two big groups that we want to help. One are people like me and many of you in this room who have never had any neurological disorders. The drive here is to prevent us and our future generations to developing it. And the other group, of course, of those of you in the audience who have been unfortunate enough to develop a condition associated with the brain and nervous system, there is much we can do to improve the outcomes of people who have disease already, and it's worsening. So it's in this spirit we're all gathered together. I welcome you all, and we look forward to what is going to be, I think, a fantastic session today. So without further ado, I'll introduce Kate Drummond to get the ball rolling. Thank you very much.
Thanks, Jeff. I'd just like to echo exactly what Jeff said. Certainly when I started in my area, which is brain tumours, we had very little evidence for anything we did. We didn't really have evidence that any of the surgery we did made any difference for patients whatsoever, and the only thing we knew worked a little bit was radiotherapy. But since then, a plethora of new promising therapies have arrived, and interestingly, certainly in the US and increasingly in Australia, it's been consumers and patients and families who have found themselves in the terrible situation of having a brain tumour who have driven this new research, really asking the question, can't you do more? What can you do to do more? So forums like today are incredibly important, and I think this is somewhat unique, certainly in Victoria, and we really welcome all of you here who are consumers or advocates or patients or however you would like to be addressed. We welcome you, and we really value your participation here. So to get the ball rolling and to sort of set the tone, we have two keynote speakers, both from really premier advocacy and consumer groups in Australia. And I'm very pleased to welcome Erin Lalor, who is the CEO of the National Stroke Foundation, who tells me that her background is a speech pathologist, but you know, one of the organisations that has driven exactly what Jeff has been talking about, having some evidence, knowing what's the right thing to do next, what is going to help for the future. So thanks very much, Erin.
Thanks, Kate.
Sorry.
Yes, I do need. Just working out the technology. So I've been asked to just give an overview of partnerships in the NGO sector. And I thought that one of the ways that it might be helpful to illustrate the potential of partnerships in our sector is to talk through some of the partnerships that the National Stroke Foundation has been a part of. But before doing that, I thought it would be helpful just to go through sort of the background to what a partnership is and how we can have various types of partnerships. So if you think about it, really a partnership is about two or more independent bodies working collectively to achieve more effective outcomes than they could by working separately. And in the NGO sector, that's really important. We're a resource-limited sector, and we need to be able to work smart with the resources that we have. And if you think about it, there's been a number of incredibly successful partnerships that have delivered fantastic outcomes. So Steve and Steve, Job and Wozniaks, who sat in a garage many, many years ago and created the first Apple computer, to Ben & Jerry, who I understand create some of the world's best ice cream. Partnerships are very much about working together to be able to achieve something more than we could achieve on our own. But it's important to understand, and it's been important as an NGO to recognise that not all partnerships are the same, and that the nature of the partnership is driven very much by the outcomes that you're looking to achieve, as well as some characteristics of the organisations or individuals who'll come together and the work that they're looking to achieve together. And this partnership model actually comes from the Victorian Health Department, and it looks at the continuum of partnerships starting really at a networking level, where individuals will be able to come together like we are today, to share ideas, to talk about opportunities, to understand where there are commonalities that would allow us to move along the continuum to the end point of collaboration. And part of the stages of partnership also involve a coordinating mechanism. So once we've all come together today, what are the steps that we would take to ensure that the good ideas that come out of our discussions will enable us to be able to move forward to deliver the good outcomes that we know that partnerships will have the potential to deliver? So the partnership continuum is based very much on a whole lot of factors, and one of them is commitment. So it's commitment to a shared goal. And I think from an NGO perspective, one of the things that we understand is it's incredibly important that we create partnerships around shared goals and visions. If we don't have partner organisations that are aiming to get to the same point that we are, we spend a lot of time trying to bring the partnership to a common goal, rather than talking more specifically about how we can deliver on that. But the continuum's also based on the amount of change that is required. And in some instances, the partnerships that we've formed have not required significant change. So it's been much easier to work at the beginning end of the continuum, where it's simply about communicating with individuals and networking, as opposed to where significant change is required. So, for example, the National Stroke Foundation works very closely with clinical groups to try and drive improved quality of care in stroke. Now that requires an enormous amount of change. And so it's really important that we operate more so at the level of collaboration than simply at the level of networking. Partnerships will also be based on the degree of risk involved. So we think very carefully about the risks to each individual organisation. And one of the things that we recognise is that there are risks associated with an organisation's attempts to be able to move forward in a space when they're doing so with another organisation that may or may not have similar stakeholder relationships. So in some of the alliances that I'll talk through, I'll explain how that becomes really important in us being able to develop a solid partnership. So you can see that the partnership continuum is something that I think it's important for us to bear in mind when we're talking in our workshops later this morning, to really understand, are we talking about a partnership continuum that sits right down at the level of collaboration? We're really looking at opportunities where our networks will be able to help us deliver more. So in the NGO sector, we have a very diverse and rich stakeholder group. And it allows us to be able to develop very powerful relationships and partnerships with other organisations and groups. So for the National Stroke Foundation, these are, and I imagine for many of the NGOs that are sitting in this room, these are the stakeholder groups that we work with, and we explore partnerships to achieve common outcomes. So some of the key partnerships that we have as an NGO are our consumer groups, the clinical groups and other NGOs. We use corporate partnerships in some instances, but most of our partnerships are based on the conversations and the networking opportunities that we've developed with our stakeholder groups. So if we think about partnerships, why do we want to have them? As I mentioned at the beginning, the NGO sector is resource poor, so we're often thinking about how we can do more for less. So partnerships provide us with a really great opportunity to increase the resources and the reach of our programs. So if we can find others who will contribute money or thinking or bodies or networks to help us get our messages out, that will allow us to achieve our mission much more successfully than if we do it alone. One of the really important values that we find in stakeholder and partnerships, stakeholder relationships and partnerships, is that by communicating with others who work in partnership with us, we have an opportunity to broaden our thinking and our ideas. It creates a richness in the programs that we deliver, in the advocacy positions that we take, and it ensures that when we move forward with a particular activity, we are doing so in a fully informed way. And that, importantly, allows us to reduce duplication. There is a coalition of stroke organisations in Australia called the Australian Stroke Coalition, which brings together 15 organisations that work in stroke, from clinical networks across the country to the College of Physiotherapies, occupational therapists, physicians, general practitioners, ambulance, etc. And that coalition, that partnership, was developed primarily to reduce duplication. So we recognised that various organisations around the country were doing the same thing because we all saw the same problems. And we often came up with similar solutions. But what it meant is that we weren't using our resources in the best possible way. So that coalition has been meeting since 2008 and has recently identified a key topic for focused effort amongst the partners within that coalition, which will really look to drive quality improvement. And that process has been based very much on the factors that I mentioned at the very beginning on the continuum of the partnership model, in that we all had to work out what were our common goals, what were the areas that we all agreed the most change was required, where was there minimal risk or risk we could manage in moving forward collectively to achieve the goal we were looking to achieve. So similarly to informing thinking and decisions, one of the fantastic opportunities, and I think it will be great to have the discussion amongst the smaller groups this morning, is to encourage innovation. We all look at a problem with a different set of lenses, and we all look at a problem based on our experience and our thinking. And partnerships really do give us an opportunity to think beyond the square that we live in. So I think this is a really important part of partnerships and one of the aspects of partnerships that we'll be able to explore more this morning. And then, of course, it's really a no-brainer, as someone said to me the other day, that it allows us to broaden our messaging, our work and our efforts beyond the NGO sector. So I just wanted to talk through a couple of partnerships quickly that the National Stroke Foundation has been undertaking probably over the last 5 years predominantly, that have really looked to capitalise on the benefits of partnership that I've spoken about before. So this is a partnership that includes other NGOs. I'm not sure if I can get a pointer. Oh, I can. So the Pharmacy Guild of Australia, us at the Stroke Foundation, but also some community groups, Rotary, YMCA, and some corporates. Omron are a blood pressure manufacturer, and RACQ is the Queensland equivalent of the RACV. And the Know Your Numbers program was developed and piloted by the National Stroke Foundation based on a UK program in 2007, which aimed to get more people to recognise that they were at risk of stroke, to ensure that people who might be at risk were getting to their general practitioner to have a proper assessment and to be given information about how they could reduce their risk. So the program sets up what we call pressure stations in pharmacy, which is why pharmacy is such an important partner for this program, but also in community groups, which is why our community groups are such important partners. And it allows people to go into those settings and to be able to get their blood pressure checked, to answer a range of questions about other stroke risk factors, but also to have a diabetes risk assessment done, which is now happening in Queensland and New South Wales. And what this partnership has allowed us to do is to provide those free health checks and standard educational resources to thousands more people than the National Stroke Foundation would have been able to do on its own. It's allowed us to support the delivery of health information and information generally about stroke and stroke risk. And it's also allowed us, importantly, to collect evaluation data. So our partners collect information that allows us to continuously review the program, to continuously improve the program, and to be able to understand whether the program's really having the impact that we want it to have. And you can see on the next slide how our partners have allowed us to achieve significant growth. So they've allowed us to reach beyond what we would have been able to achieve alone, to the point where in 2012 we've got close to 19,000 now pressure stations on the eastern seaboard, and we'll be checking probably close to 200,000 people this year. And about half of those people, concerningly, are referred to their general practitioner for an assessment because they are likely to be at increased risk of stroke, and most of them had no idea before they came into the pressure station. One of the other partnerships which has also been in play for many years, probably closer to a decade with this one, is the National Vascular Disease Prevention Alliance. And this is an alliance of the 4 NGOs. So this is an example of partnerships of NGO within the NGO sector. So we've partnered with the Heart Foundation, Kidney Health Australia and Diabetes Australia to jointly tackle the burden of disease caused by our respective diseases. And this comes back to the importance of having shared goals and shared commitment to those goals and activities that will allow us to be able to sensibly and pragmatically achieve a common goal. So the NVDPA has really been exploring ways in which these organisations can work together to achieve the best outcomes for people with the chronic diseases. And we look predominantly at developing and implementing clinical guidelines, which is about taking what we know, what research has proven works, and looking at how we can get that used in clinical practice. We've also looked at how we can influence the quality and effectiveness of vascular disease prevention programs. And we've looked at ways that we can work together around advocacy issues for people who are affected by vascular disease or any other related purposes. And one of the key pieces of work that this alliance has undertaken was the development of clinical guidelines for the management of cardiovascular disease risk. So previously, we were all spending our time working on developing separate guidelines. So the Heart Foundation had its hypertension and lipids guidelines, diabetes had guidelines for prevention of CVD in people with diabetes, kidney had the same sort of guidelines for use with people who had impaired renal function. And it was causing confusion for consumers and for general practitioners, and it was requiring an enormous amount of resource from all of the individual organisations. And it was not an easy partnership. To get agreement on targets, on clinical recommendations was challenging when we had to accommodate the various views of the four groups within the alliance. But we got there in the end, and these guidelines were released in 2011. And they incorporate all of the recommendations that were previously in the other guidelines. And so this is now about joint messaging to government. Getting the guidelines written and getting them implemented are two very different things. So we've been talking to government, we've been talking to clinicians, and we've been talking to consumers about how we can get messages across that we no longer want people to think about their blood pressure, for example, in isolation. We want them to think about their risk factors in the context of their overall risk. We've also identified the barriers that we, as an alliance, can jointly approach. So some of those include regulatory barriers where the listings for some of the medications recommended in the guidelines aren't consistent with the recommendations in the guidelines. So there's a lot of work being done around removing some of the barriers to their implementation where we can work together, but also educating health professionals and pooling resources. So once again, we've said, let's not all go away and do the same thing differently. Let's talk about what needs to be done and do it together. I think this might be, oh no, I've got one more to speak to after this, but this is probably one that I'm particularly passionate about, and this is partnering with consumers. So for many years, the National Stroke Foundation has relied on consumers to provide advice about the way that our programs are run, about the priorities that we choose to target as an organisation, and about the advocacy messages that we take to government. But in recent years, we've been getting an increased volume from the consumer voice, where we are hearing more and more that the situation is deteriorating, that services for stroke in Australia, particularly in the community sector and long-term recovery, are nowhere near what they need to be to support people who've had a stroke in the community. And in light of that, we recognised that we needed to, harness the consumer voice, to gather and allow and provide a forum in which consumers would be able to talk to the people who could make a difference to that. For a long time, the National Stroke Foundation had been advocating to government, but we recognised we need more voices to be able to get that message to be heard. So last year, we embarked on a campaign called Fight Stroke, which I'm hoping all of you have signed up to, and if you haven't, go to fightstroke.com.au and sign up. Doesn't take long. And the Fight Stroke campaign is really targeting our federal government to say that enough's enough, that from a stroke perspective we have very good evidence about what makes a difference. And we have very good information about what consumers believe that they need. And last year, before we actually went to government to say this is what needs to happen, we understood the importance of being able to consult with consumers to make sure that what we were saying needed to happen was what consumers believe need to happen. Particularly given that the number of people who are living in the Australian community with stroke is increasing. So when I started in this role, I quoted a figure of 120,000. That figure is now 420,000. So we used mainly networking and consultation to get consumers to help us to develop this call to action. So we have a Consumer Council, and John Damerow here is in second row with his hat on, is one of the members of our Consumer Council, a group of 10 stroke survivors and carers who advise the National Stroke Foundation. We also held forums around the country with 300 survivors and carers who talked to us about what was the issues they were facing. And we surveyed close to 1,000 stroke survivors and carers, with Dominic Cadillac leading that research project, to really make sure that we had a solid understanding of what the issues were. And then we established a writing group of stroke survivors and carers who developed this call to action. And in releasing that call to action, we knew that we needed consumers to be the voice that took that to Parliament. So 70 stroke survivors and carers came with us to Canberra in October last year, where the call to action was delivered to government, and survivors got an opportunity to be able to say enough's enough. So very powerful partnership for stroke and for the National Stroke Foundation, and goes beyond many of the other partnerships that we have, because it's partnerships with individuals as well as partnerships with organisations. And then the last partnership that I wanted to talk about is a project called Stroke 123, which is an NH&MRC funded partnership project, and Dom's here in the audience. This is a project that has a number of research groups involved in it, a number of NGOs and a number of government and clinical groups. And this is really, I guess, the ultimate partnership, because in this instance these groups aren't just coming together to say how can we work together, but they're putting some skin in the game. So some of these organisations are contributing money, some are contributing people, some are contributing technology, but everyone is contributing to the project to be able to achieve the end result. So just in summary, as I said at the beginning, the level of partnership that we will develop as an NGO depends on the outcomes that we're looking to achieve, as well as the organisations and individuals that we're working with. It really does have the ability to increase our resources, our reach, to inform our thinking, to reduce duplication, and to encourage innovation and an ability to broaden what we do beyond the organisation that we work within alone. But they're not easy. Every partnership that we undertake, we spend a lot of time working out, are we actually heading in the same direction? What does the goal look like? And how do we make sure that we are united in achieving that goal? But I think the absolute gold standard of partnerships, and ones that we're starting to explore, is moving from many organisations having related goals to many organisations who work together to achieve a common goal. And this is one of the partnership models that we've been exploring for probably the last 8 months, particularly with the Australian Stroke Coalition, and it moves almost beyond the end of the continuum that I've been describing. But the potential from partnerships is significant, and I think that we know that if we harness the efforts from many, many organisations that have their own networks, their own information, their own thoughts and ideas, their own resources, the ability to be able to achieve critical mass and achieve much more than we can as an NGO working on our own is very significant and really, really exciting. So today I'm really looking forward to being able to talk more with people about that.
Thanks, Erin. So following on very nicely from that fantastic overview of the sorts of partnerships that we'd like to achieve, I'd like to introduce Sharon Strugnell, who's a friend and colleague of mine, who is the CEO of Brainlink. This is an organisation in Victoria that caters to the needs of the carers of those with an acquired brain injury. And the neurosurgery ward at Royal Melbourne Hospital has had a partnership with Brainlink, which she'll tell you about, for almost a year now, which has been an incredibly successful venture. And Sharon's going to give us a bit of background on Brainlink and also about this partnership. So thank you for welcoming Sharon.
Good morning, everyone. I haven't got overheads, so I'm just going to be speaking about our project. And I want to say, first off, thank you very much for inviting me here again today. And I think it was really exciting coming back after last year, because at last year's forum, we were about to embark on our partnership, and it was in the early stages and we hadn't even begun. And so I was sitting in the audience and I was listening to some of the projects and some of the thinking that was around, and that was giving me ideas about what was going to happen in the 12 months that we have just seen. And so it certainly, I believe, today has been a great initiative, and I hope that it continues year after year. So a year later, here I am to tell you about the success of Brainlink on the ward. I'll start a little bit by just telling you briefly about Brainlink. Kate's already given you, in a nutshell, I guess, what we do, and that is about supporting families and carers first and foremost. Everything we do is to, we hope, reduce the impact of an acquired brain disorder, whether it's through a traumatic brain injury or a degenerative neurological condition, brain tumours or other acquired brain sort of disability that might happen to somebody. What we do best, I believe, is inform and support families and assist them to navigate the disability system. We focus on carers and family members who support a patient, as we strongly believe if we can help them sort out their practical issues, then the families have time to deal with all the emotional and difficult side of things when a loved one is seriously ill or having to deal with an injury that may require lifetime care. We deliver support education programs, lots of creative respite, social activities which are really important when families are having to live every day with difficult situations, and specialised case management for individuals with catastrophic brain injury. Quickly about me, I've been CEO of Brainlink since 2004 and fully understand the distress and the bewilderment, I guess, that families feel, especially when a loved one is in hospital. I can say I truly walk in the shoes of the 500 plus families that Brainlink supports each year. And that's because in my own family, I have a husband with Parkinson's disease and an adult son who suffers schizophrenia. At Brainlink, we talk about changed lives when someone sustains a brain injury or is diagnosed with a degenerative neurological condition. Good or bad, the changed life, because it could be either way, for the individual and for the families, for carers, for friends, for workmates, and everybody that surrounds that person. For Brainlink at the moment, as many of the organisations that are represented in the audience today, we're in an environment of tremendous and rapid change and reform, and certainly in the disability area of what everyone refers to all the time of a broken, fragmented and extremely confusing disability system. But for all its faults, and we strongly believe that the Victorian system is way ahead of the rest of the country, Brainlink does know a lot about the current system and the best way to refer people through it. The Brainlink team also know that real reform will only work when the interface between individuals' journeys from hospital to the community, with all the people in between, allied health, palliative care, GPs, aged care, when all of those people come together and they work together and they share information, they share their expertise in the best interests of patients and families. I'll touch on very briefly, because I guess it's topical at the moment and many of you will have heard it through the political chatter. The National Disability Insurance Scheme, or Disability Care Australia as it is now known, will commence on July 1. No doubt some of you will have heard of it, and whilst I'm excited, we still have a long way to go to ensure its success. It will rely on us sharing our expertise, whatever it ends up being. Be it medical, be it clinical, be it research, be it community. We all need to continue working in partnership for the best outcome for patient and family, in many cases for their lifetime. Whilst all this reform and the challenges that will come with it, Brainlink believes we must keep on going with all of you to better the health, the social and the life outcomes for people in Victoria and all over Australia. So almost a year ago today, the Brainlink ABI Crisis Liaison Officer was stationed in the neurosurgical ward at the Royal Melbourne Hospital. At the time, it was a long title, as you can hear, because we didn't want to leave anything important out. But now it will be known as the Brainlink Community Liaison. However, for many, she is Suzanne Shaw, and she's sitting, I'll get her to wave her hand, just over here, so you can all go and say hello to her later. For many, many years, Brainlink had spent numerous funds on beautiful glossy packs and brochures and special magnets and posters, you name it. We had them in wards, we had them in rehab centres. They collected dust a lot of the time. Some of them were sent out with patients and families, but we know that people in hospitals are very busy, and so it wasn't the best way to connect with consumers and to connect with families and to connect with patients. We have a fact sheet for most things in our office, and we receive numerous calls every day asking such questions as, what is the difference between a neurologist and a neurosurgeon? Or, my doctor told me that my husband has short-term memory, so will it be back next week? Or, when can my son resume kickboxing or football? He's still lying in the hospital, he's only been there 2 days, but that's front of mind for this particular family. And one that is becoming a really common trend is that my husband has just had a stroke, I have no access to money and I have no power of attorney. What am I going to do? So don't get me wrong, there is a place for brochures and fact sheets and all of those things. But Brainlink also has first-hand experience that nothing beats a face-to-face, a friendly smile and a helping hand. Somebody to walk you through and just be there and talk to you. What works best is sitting over a coffee sometimes, not saying much at all, but just sitting with a person for a short while. And so a pilot program was developed to trial the effectiveness of a liaison in a hospital setting. The expectation was that the presence of a liaison in person in a busy hospital setting would have multiple benefits for those recently treated for acquired brain injury and their families. These would include smooth transition into the community, facilitation of independence and improved health and well-being, and importantly, we hoped, reducing the carer stress. For Brainlink, it was hoped several objectives were achieved, including increasing the number of individuals and families accessing our services and raising awareness of what we could provide the acute care sector. Since May last year, the liaison has made contact with more than 200 patients and their families, and 75% of these have been referred to our services once discharged. Important to note, I just allay everyone's fears, that patients are only contacted after consent for referral is gained. What the service model has shown is that establishing a relationship with patients and families as soon as possible whilst someone's an inpatient serves as an approachable point of call for patients once they're discharged and fills a gap in the acute sector. For those wanting further referral and services, the liaison has been able to provide patients and their carers with family support, information on resources and assistance, referrals to other community agencies for specialised care, guidance as to how to seek financial or legal advice, an information hotline for emergencies, education, employment advice, support activities, and individual counselling and advocacy. Most patients that we saw on the neurosurgery ward suffered from traumatic brain injury, stroke and brain tumours. And in the area of brain tumours, what we found is that many of these families just fall through the gap. they don't seem to be picked up by anybody once they leave hospital very easily. So this was a great group of people that we were able to access. At each referral, the liaison undertook a general assessment of the care needs of the patient or the family and the potential for gaps in the community. At 6 months after referral, carers will be assessed for their caregiver strain again. So after 12 months, we're nearly there. The end of May is the end of the 12 months. Some of the feedback so far. The pilot program has received overwhelming support from hospital staff, ABI patients and their carers. Staff have noted that the liaison officer has a clear understanding of the roles of different staff members, allowing the liaison officer to provide feedback to staff from interactions with patients and families that will be important for success in therapy, but would otherwise go unnoticed. That was from a number of physios on the ward. Staff have also commented that the support of the liaison officer ensures that patients are less likely to fall through the gaps, more likely to have the advocacy they require and receive assistance to streamline the paperwork, applications that they require for long-term funding, therapy, equipment and services once they're discharged. Social workers have accounted that the liaison officer has been a complementary role to their practice and helped to ensure client-centred practice. One commenting that patients and carers have frequently voiced their thanks for Brainlink's input and have on several occasions recommended it to other clients in the ward. The nurse unit manager of the neurosurgery ward has also highly recommended the presence of the liaison officer, describing it as an invaluable service providing support, education, counselling and empathy for families and patients with ABI. She also noted that the liaison officer enhances the practice of others in the ward. Staff on the ward have sought information themselves and guidance from the liaison officer to enhance patient and family members' well-being. Feedback from ABI patients and their families and carers has also been overwhelmingly positive. One carer provided a striking testimonial to the influence of the liaison officer. I feel more confident that I will be able to cope with the practical and emotional issues of my husband's deteriorating health. Now I understand that I have permission not to feel guilty about taking time for myself. And one patient noted, the officer has provided a rope for me to hang on to during this overwhelming journey so that I don't feel like I'm drowning. The liaison officer provides services otherwise not available on the neurosurgery ward. After diagnosis and treatment of an ABI, support is via social work upon request while in hospital and the discharge nurse. However, there is little provision of follow-up in the community except through medical outpatient department appointments and various rehab options. Support from social work is limited to the provision of government forms and workplace letters, and there is no provision of community referrals except in dire circumstances. There is little provision of support for carers and no easily available point of contact for follow-up crisis. So in a relatively short time, the pilot service model of this project has demonstrated some successful outcomes and real help to patients and families and an effective partnership between Brainlink and Royal Melbourne Hospital. Erin gave us the foundation and the footprints of what successful collaboration and successful partnerships should look like. Collaboration can be a very challenging process precisely because it is a highly intense way of working, requiring new ways of thinking, behaviour and ways of operating. To really partner, it takes lots of goodwill. It's about connecting with the right people, not stepping on each other's toes, so to speak, and each party complementing the other. On either side of this project and partnership, We've had willing people willing to give it a go and champion what might eventuate to benefit patients and families. A huge thank you to Kate Drummond and the powers that be for supporting this at Royal Melbourne Hospital, the wonderful team on the neurosurgery ward, and of course my team, Suzanne, and our community liaison. So far, as I said, the feedback's been overwhelmingly positive, so much so that Brainlink and Royal Melbourne have agreed to keep the position for another 12 months on the ward. We will document the outcomes, the model, the do's and don'ts, and we'd love to interest other major hospitals to partner and have a liaison too. But for now, and I know Stephen's had to rush off, we'd like to expand the work that we're already doing at Royal Melbourne Hospital, and so I'd said that Professor Stephen Davis, we're planning next on coming to a ward near you. I know he's not here, but I know that Kate's already told him that. I know that I can see Andrew Evans is in the audience, and so we'll be saying we're coming to the neurology ward next, and hopefully we'll be able to assist some of the families there into the future. Thanks for listening, and let's hope at next year's forum that we can tell you more about the expansion of where the liaison has gone to at Royal Melbourne Hospital, and let's hope we've also gone to another hospital. Thank you.
Thanks, Sharon. I can't emphasise enough what a revolution this project has been on our ward. Previously, we knew that patients were going to go back into the community with really not a lot of support in that critical gap between discharge and their 6-week outpatient appointment. And to know that someone is there following those patients up and making sure that they have what they need, really in a broad range of things, from everything to answer to a question to a complex referral to multiple community organisations, has been an absolute revolution for us. So, I can't say how important that partnership has been for us, and I really want to thank Brainlink for funding it for the period of time that they have, and hopefully we can continue to do that. So Helmut Butzkoven's going to come and discuss the next part of the meeting before we go to morning tea now. Thanks.
I'd also like to thank you all for coming to this forum. It's bigger than last year, and that's exactly what we need to see. We can actually have reasonably unformulated discussions around purposes and aims, but I think we need to focus the discussion down. We have a key performance indicator, a mission at the Melbourne Brain Centre at the Royal Melbourne Hospital. That mission is to translate the very considerable power of research in this precinct into something that makes a difference to patients with brain disease. It's of course a craft-specific conversation for brain tumour or multiple sclerosis, stroke, the others which are listed there. But the discussion forums after morning tea should ultimately be focused on this question. How can we work together in projects that are going to change health policy or health practice? We've already heard just now from the CEO of Brainlink about such a project. Putting a liaison officer into an acute ward clearly changes acutely the quality of life of people diagnosed with that condition. Hopefully we can put a research parameter around that, and hopefully we can lobby government to see that as worthwhile funding, rather than funding it from little pots of money that may or may not be found, because this is clearly working. change in clinical practice and the impact that it can have, can range from very small to very big, but it is our KPI. Another example, actually not in brain disease, of something very small also occurred at the Royal Melbourne Hospital. All of you, maybe not all of you, but almost all of you will at some point or other have been in an emergency department. And you would have been registered by a triage nurse. They're trying to work out how bad your disease, your acute illness is, to try and stratify how quickly you'll be seen. And we all know about the delays in the hospital system in this context and the significant service challenges. One of the results of those challenges is that people in acute pain took almost an hour and 40 minutes to receive pain relief. So from the moment that you walk into the hospital and start your conversation with triage, it can be 1 hour and 40 minutes before your pain is relieved. Relief of pain, we'd all agree, is a good thing. The practice change was that the triage nurse was specifically instructed to ask, are you in pain? 1 hour and 40 minutes came down to 30 minutes. That's 1 hour and 10 minutes of pain on average saved for every person in pain walking into the Royal Melbourne Hospital with a minuscule change. The biggest change that we can hope for as clinicians and scientists working in a disease is, of course, to make our jobs completely redundant. That's unfortunately unlikely, but if we can actually cure a disease or reduce its impact to the point where we're virtually not needed, that would be the best possible outcome. But short of that, there are little or big things that this forum can achieve. For each of you in the craft groups, I want you to try and stick to that KPI. How is the projects that are being discussed? They should be coming either from the Brain Centre staff or from the community, from both of us together. How can they potentially achieve a change in some aspect that's going to become routine? Another, I guess, small thing, if we achieve nothing else, is to try and proliferate hate. As people suffering brain diseases, their carers, their loved ones, there is at least a certain amount of hate for that disease. Nobody likes being diagnosed with schizophrenia or MS or Parkinson's or have strokes, and the impacts are massive. And as clinicians, as occupational therapists, physios, nurses, doctors, looking after people with brain diseases, we share that hate. Kate Drummond, as a neurosurgeon, has to see hundreds of people in her lifetime die from acute brain tumors and share a small part of that journey over and over again. And I'm sure she hates that. Some of the scientists working with us at the front end of research in brain disease need to come in contact with people who suffer the brain diseases, because when they're sitting there at 8 p.m. putting some solution on some dish somewhere, it would be helpful for them to remember contacts or to have contacts with the people whose disease they're actually working on. And that was actually a big feedback from last year's session, is that many of our scientists working in the more basic and less applied fields haven't seen or had contact with patients, sufferers and caregivers of the disease that they're working on. I suspect that this, even just that contact, will provide them with a markedly increased level of motivation for the work that they do. Everybody has to, I think, see where their work can fit in. So the craft groups are going to meet after morning tea at 10:45 to 12:15. They will be co-chaired by a member of the MBC and by a member of the community. patient representative organizations or patients to have these conversations. The outcomes are going to be varied. Some craft groups might decide to work together on a specific project, and they might work together quite intensely, and that would be a great outcome. If there isn't that kind of motivation, it's really just a matter of opening up a channel of communication that's also good. And we're going to leave that up to the groups, the 6 groups that are going to meet after morning tea. Is Fiona in the room?